Good afternoon. This is Doug Farquhar, Director of Government Affairs with the National Environmental Health Association. Today, we're going to be talking with Bob Powitz. He is a sanitarian, and he takes that very seriously, that he's a sanitarian. He's been with the industry since the 60s, and he has been probably the foremost thought leader of this profession for the past 50 years. And so we want to chat with them. Where we come from, where were we, where are we now, what can we expect in the future? So with that, I'm going to turn it over to Bob. Bob, welcome to the show.
Thank you so much.
Why don't you tell us a little bit? When did you graduate? Why'd you get in this field?
This is interesting. Getting into the field, I lived in New York City. I grew up in New York City. And before we can get working papers, they had a farm cadet program. And I was assigned to a farm in Schoharie Valley, New York. And my first week out there, I was 13 years old. A uniformed inspector from Paterson, New Jersey, his name was Ben Wax, came and inspected the farm because this was milk shed for Paterson. And I asked him a lot of questions. And since I was 13, I wanted to be a sanitarian. So it was one of these, he made an impression. When I graduated college, graduated from the University of Georgia in 64, State University of New York in 62. I spent a year kind of with the state health department, and then I got my license. The minute I got my license as sanitary inspector first grade, I went to Paterson to see Benny Wax. Okay. He remembered me. So then he pushed me, he says, well, you've got to join the National Association of Sanitarians, which I did immediately.
And that became NEHA.
That became NEHA in 1970. And I was then worked myself up through the Secretary Treasurer of the New Jersey Association of Sanitarians, which is now New Jersey Environmental Health Association. Then he also pushed me and a couple of the others to get my master's, which I did in the early 70s. But what I did, I was part of the community program with the state health department in New Jersey. And then I went to institutions and agencies, and I fell in love with institutional environmental health. So both my master's and my doctorate are in institutional environmental health with a full major and two majors outside of environmental health, because it was all paid for under Title I funds and Veterans Administration. So I took a full major in epidemiology and another one in environmental microbiology.
So we got that's 3 masters?
No, just one master's, MPH. Okay. But I was on what they called a super master program. They had a Title I fund. And when I graduated with my MPH, I spent an extra year. So I had 154 credits for my master's. And that's when I loaded up on epidemiology and environmental health. Then I came back to New Jersey. I worked back in my institution. Then I took a job as a health officer. I got licensed as a health officer. And then I got a call from the University of Minnesota if I wanted my doctorate. I was the first PhD student in the institutional environmental health program under Dr. Donald Vesley, Professor Richard Bond. So this was really a golden opportunity. And then I finished my doctorate in 1978. Okay, so then I took my postdoc at the NEHA headquarters in Denver.
Yeah, talk to us about that. Why did you come on with NEHA? What did you do there? And you were a consultant?
No, we got a grant for looking at what we call the KSNAs, knowledge, skills, and attributes.
Okay, meaning NEHA got a grant? Or
NEHA got a grant. And this was really the This was the new age. There was one that was done before, and then of course the 1936, uh, basically knowledge, skills, and abilities done under Mangold,
Okay.
under Mangold's
For
direction.
NAS?
So for NAS, well, that was the one that was done for Mangold was basically a master's degree
Okay.
in public policy.
Mhm.
So that was adapted by NAS, National Association of Sanitarians. Then I guess there was another one somewhere in the 60s, but very crude. And then under Larry Crone, who was then the executive director of NEHA,
All right.
we got the grant, and I came out and we did basically, this was the 1979 or 78 KSNAs. And I spent a year there, and then I went to Michigan and worked at Wayne State. I worked as a hospital epidemiologist, and then at Wayne State for many years as director of environmental health and safety and associate professor.
Okay, so what did you learn from the KSA? How did it transform from 36 to 78?
It was interesting. I think there were two things that happened. One, I think the 36 one done by Grace Loy was far more comprehensive.
Hmm.
It was detailed. It was very much like the British approach to environmental health, and it was actually a parallel to that. I think his name is Boyd that did the book in the UK. It also it expanded a few things in terms like air pollution and so on, but it didn't go as far in housing and so on. It was quite a bit different from the 36, and it didn't go into the kind of detail that there was. I think what was significant about it is that there was a preconceived idea that we as sanitarians had three layers. One was entry level, the other one was professional field level, and the third one was administration. My job was to send out about 2,000 questionnaires, which we drew up. And when they came back, the giants of the industry identified as technologists, not as administrators. And it became apparent at that time that administrator is no longer sanitarian as such. I mean, they're administrators. So I presented this at the Snowmass conference, and the backlash was unbelievable. They said, no, so it was basically, we've been living under the idea that you're good technologically if you're an administrator, but now you don't do anything in the field. So, and everyone who was anyone in NEHA, I mean, the giants of the industry, I can name them, they all identified as sanitarians.
Okay.
So that was a biggie. And there was some at that time that said, no, no, no. And I think we've been suffering from that. We think that the highest thing you can attain as a sanitarian is to be an administrator. And I really recently wrote a blog basically saying, no, the one who's most technologically competent should be the highest paid in a health department, not the administrator. You can buy any administration. So that was basically how that changed.
Mm-hmm.
Since then, I've seen a shrinkage in what we do.
Meaning sanitarians.
Meaning sanitarians. When I started, I was basically a milk sanitarian. We did all the ice creams. We did dairy plants. I did high temperature short times. I did the batch pasteurizations. All of this, the radiological milk program, that disappeared. Uh,
What do you mean
we
that disappeared? We don't do that any longer,
we don't do
or
that anymore. No, no. Very, very few departments do that. That's all gone to agriculture.
oh, okay, that's what you're
So
talking about.
yeah,
It's still being
yeah.
done. It's
So
being done by a different department.
by a different party, but no longer the profession. Um, there are a couple other things like housing we did that no longer is part of the profession.
Okay, whoa, whoa,
This
whoa.
is, yeah,
Now, it's no longer part of the profession. Has it moved to a different agency, or are you saying that we don't do indoor air quality anymore?
we don't do indoor air quality. That's gone to the industrial hygienist. We do lead, of course,
Mm-hmm.
but the actual housing, the traditional housing, the uh, APHA housing, CDC housing manual,
Right.
that is no longer done by us. Uh, there are a couple other programs that we used to do. We used to do, actually, um, as part of our group, we went into food manufacturers.
Okay.
We don't do that anymore. We do strictly retail. So the
Mm-hmm.
the what's happened is our well with the William Steiger Act and then EPA formation and so on, many of these programs have were taken away or we lost them.
Okay, now let's flesh that out a little bit.
Okay,
You started as a sanitarian, National Sanitation, National Association of Sanitarians,
sanitarian, yes.
1970. We get the formation of EPA. We get the formation of NEHA, which is, changing our title and our name. So all of a sudden, we've gone from sanitarians to environmental health professionals. And the other thing that was very interesting is we lost the connection to the departments of health. We became independent. We started creating this own um, departments of environment in the states, and it's and not all of them were universal, but a lot of them, they lost environmental health programs, lost their connection back to their core, back to health.
Yes,
And
yes.
it's very reflective of what was going on federally. So what did we lose?
Uh, I think we lost the technological skills.
Mm-hmm.
Here, let me give you, for instance, um, we rode around with smoke scopes, Railman,
Nope. Okay.
smoke scopes. We used to do air pollution. Now it's gotten to be nuisance complaints, basically. We used to do water pollution,
Mm.
actually looking at sewer outflows and this kind of business. And we used to do potable water, community
Mm-hmm.
potable water. We've lost those basically. We still do wells,
But they
but
go over that one over to the environment
to the
section. It
environment,
became a
exactly.
permitting thing, and it wasn't based on health. It was, I'm
No,
not going to say it was not based on health, but you get a permit, it's because you filled out the forms, not because
well,
you're,
it
you
it
know,
it, it
focused on
shifted.
sanitation.
Health came along with it. Don't get me wrong.
Mm-hmm.
Health came along with the permitting. So because there's been improvements, but it's gone out of our jurisdiction as sanitarians.
Mm-hmm.
You, you, there are basic sciences that we follow, and we should be trained in environmental microbiology, environmental ecology, uh, contamination control, risk assessment. That
Yeah.
was and
Mm-hmm.
that was a biggie, and
What about
epidemiology.
epidemiology?
Yeah,
Yeah,
and
epidemiology.
epidemiology along with biometry,
Okay.
so that we can interpret what we see and we can cross over from, say, uh, we can go from air pollution to water pollution to food to wells, everything
Yeah.
that was because the basic sciences remain the same.
Mm-hmm.
They remain the same.
So it's food and water. It's what is in the environment that we take.
Exactly. So it was everything, and then that was stripped away from us as a result of basically William Styrak when we lost we used to do the industrial hygiene to a degree, and then of course the environment that we lost as well. So that was the change that we saw. And
Go ahead.
recently, I think when I started as a sanitarian, we were working with the 1965 Food Code.
Okay.
1965 Food Code empowered us to actually look at the food service establishment and its operation very much like you would do a plan review or what is now HARP C, HACCP or HARP C.
Okay.
That then became structured in terms of food code. And now it's turned into an AI exercise.
Mm-hmm.
So the science, the application of science is not there. And I say that this has happened throughout our profession. And I say that because since 1985, I've been doing environmental health forensics. I started working for attorneys. And I've been on a lot of contamination cases and foodborne cases and so on. The one thing that I found that does not help, and I know I'm going to get smacked across the face for this, is when you get the inspection reports, they tell you nothing. Simply because.
Okay, what do you mean by that? Explain.
Well,
Explain.
understand there are like the food code has us looking at what 110, 120 things.
Okay.
In all my 50 some odd years as being a sanitarian, I have never seen a light bulb break or shielding of a light. Never. I've never even heard of it. Yet, when we go in, we have to look at that. So if we have to look at 120 points, what we're missing is oftentimes what I call, we're looking at floors, walls, and ceilings and missing the essentials like time, temperature, pH, water activity, handling, traffic patterns, the stuff that hand washing, we miss that simply because we're looking at the things that are mandated, and that has turned into an AI exercise. And when I go into the restaurants that hire me for whatever it is, I look at it quite differently. I don't even need food code. I can apply something like good manufacturing practices or the HARP C, which is, I think, one of the greatest things that happened with the Food Modernization Act and HACCP. And if I do that, I have now looked at the operation. It takes me a little bit longer.
Yeah, but this is what you're going for here. You got the food code, which is procedural, but you need to get substantive. You've got to make sure that substantively, regardless of what the food code says, you've got to make sure no one's going to get sick.
Exactly. And I think that we've kind of lost that. We make up for it in numbers, and I'm not saying that's a bad thing. I mean, if you go in 4 times a year into a place, or even once, twice a year, you see certain things, patterns develop. That's fine. But for me, if I'm going to go through 4 years of school and learn the fundamentals of environmental microbiology and of epidemiology and so on, I should be empowered to use that rather than,
which helps the retailer, helps the restaurateur to say, they need to learn, not their problem that they have meat on the floor, something like that.
The other things that we've lost I had a very good mentor when I
Okay.
started. His name was Ray, and he never had college. He came
Hmm.
out of the U.S. Navy, World War II, Ray
Sure.
Chapman,
Okay.
and he was within the Navy. He learned this skill. And let me tell you something, I've never seen a better sanitarian in my life. And he
Hmm.
taught me. I think we've lost observational powers over the
Okay.
years. One thing that I'm seeing that I'm critical with, instrumentation. We're not taught that.
Hmm.
And it's fundamental. You take a thermometer. Well, there are ways to take a thermometer, and there's a way to sample so that it becomes statistically significant, even if you're taking just one, but it's also repeatable if there is an error. We're not, I don't think there may be a handful of health departments that actually look at pH and water activity, and yet they're in the food code. So, what I'm trying to say is that we expect from our profession a degree of excellence when it comes to credentialing.
Right.
But the translation in the community is quite a bit different. That expectation goes down. And if I were now a politician and I had to evaluate someone and rate their, how much are you worth?
What's your value?
What's your value? And to me, this is why I wrote, I would like to see the best and the brightest being the highest paid. And don't bother with this prescribed environmental health approach.
Now let's take
Become a
you got it.
sanitarian.
Right. And let's take that a little bit step further because we got a real interesting as a public health profession. We're really interesting in the sense that we're not dictated by the federal government. Yeah, we got the food code and we got out there. But if you're a local health department, you're fee based, you are providing a service to your local community. They pay you to come in to make sure the restaurant is going to meet the standard and not going to harm the community. You're going to make sure that the wastewater system is not going to hurt the community, and you don't go down the path of, well, we got this federal requirement, we've got this. You're really local based, and that's what the
Well,
policymakers need to know.
yeah, but that's a yes and no. I was here in Connecticut. I was health director in several communities until
Mhm.
I I said no more. I had more unfunded mandates than I had funded mandates.
Coming from the feds, the state,
The
or the
state,
locals?
the
The
state,
state.
the state. And we had to do this with
Uh-huh.
money that was not forthcoming because we were too small.
Sure.
So the state was not paying for anything. Feds were not paying for anything, but we had to do it. So I looked at my communities and I said, no more of this business because what I was in Eastern Connecticut, rural, agricultural. My needs were quite different in public health than,
Mhm.
say, someone in an urban area like New Haven or Hartford or New London or Danbury.
Sure.
Quite a bit different. So, um, where it was structured for the urban area, it was not structured for the suburban or the rural community.
Well, that's
And
interesting.
we still had these unfunded mandates.
Right.
In other words, what I'm trying to say is I can take any good sanitarian
Hmm.
and have that individual go into a municipality, whatever size it is, and within a week, they can tell me where the problems are just by running around.
Okay.
If you see that, you address it. And this is how I was taught. Growing up, we did model cities. This was one of the things that I had Hoboken, New Jersey, as one, in Newark, New Jersey, as another in model cities. when that was in effect. Well, we did the housing, we did the restaurants, we did everything anything that we saw and
Okay.
anything that was reported to us from, say, the hospitals or something like this. This was uh, this was a community effort that was involved in, and we then worked with public health nurses, with physicians, with public health workers, whatever they were, and we started addressing problems. And it was
Okay. It
an
was local based
absolute
problems.
local based, and it
Right.
was absolutely fantastic. But we were working in our profession. We were not.
So, so
What's
back,
happened?
so
Let
back when
me
you go
let
to
me.
Connecticut, though, I gotta finish up that your
Okay.
thought process here.
Yeah.
Um, in Connecticut, it wasn't a community, the local based requirements. These were mandates from the state without money.
Right.
And
Correct.
they
For
were coming
small
up
communities.
saying, so the policymakers or whoever were saying, this is a problem. This is what we want them to cover. But that wasn't applicable
No.
to Eastern Connecticut.
No. In a lot of it. Now they've joined in the larger health departments, but nonetheless, it still is underfunded. But
Right.
the emphases are not there on the things that we should be looking at, and that going into schools, looking for
Okay.
other than going into the cafeteria,
Let me
because
talk
that's
to you a
stuff that
little bit.
happens.
Okay. Just you're running your experience there. Where do you see the problems in a average community? Where should the effort on environmental health be invested?
To me, housing for sure,
Okay.
because people live
Private
there.
housing
Private
as
housing
well as public. Okay.
as well as public, because there's a population that's between 18 and 65 that kind of leave and go to work, but they still come home, and so within 16 hours in a day, they're home. So they're spending
Okay.
their time there. We should be spending our time uh, looking at uh, basic neighborhood and neighborhood facilities. The talk of environmental justice is, to me, huge BS, because I say that with a capital B and a capital S, because environmental justice means you simply do what you're supposed to do if you see something wrong. The codes are there, so you straighten it
Okay.
out.
So the big issue, housing, looking at the community, looking at the public
Yeah,
things in
schools,
the community,
schools.
schools,
Oh, yeah.
community centers,
Oh, yeah.
school. You brought
Schools.
schools up.
Schools, remember, we have children are subject to injury,
Mhm.
unintentional injury. Do we go in and look at how many look at playscapes and know how to evaluate a playscape in a school? We don't. And this
Okay.
is where the injuries are. This is public health. How many look at indoor air quality?
All right.
How many
Carbon
look at,
monoxide.
well, not only carbon monoxide, but carbon dioxide, dust, you name it, from allergens on through. How many look at ergonomics within a school? What are we doing with our kids? This is fundamental, and yet most, I'm not saying all, but most simply go into school, take a look at the school cafeteria, do the check sheet, and they're gone.
What about
That,
what would nursing homes be one of your top areas
oh
that
God,
you need to
yes.
look at?
Oh yes, of course. Simply because you have a given population there that has
Right.
a different. Let me back up a little bit. Institutional environmental health
Okay.
works first with the population. You center on the population. I have several prisons that I work with yet, and I have one that I'm contracted with and I have been contracted with a long time. Public health is not first and foremost within my incarcerated environment. What is first and foremost is security. So
Okay.
everything I do has to be wrapped around security. My food service, my sanitation, my warehouse, my laundry. All of this is wrapped around security. I have to fit environmental health in there because I still have 40% of my population with bloodborne diseases. I still have my staph aureus. I still have all of those things that are inherent with that uh, within the criminal justice system. So how do I do this? And this is the sanitarian's job to fit this in. Not that you're going for environmental health and saying, well, you got to do that. Most of the times they can't simply because there's a barrier or traffic patterns or something like this. We have to learn how to fit environmental health within a community. And
So
this
same
goes
thing
back
with
to
going into schools, same thing going into
exactly
daycares,
correct.
same thing going into nursing homes.
Hospitals, nursing homes, daycare centers, doesn't matter. And the issue of environmental justice, the same thing. How do you get to that neighborhood?
Mm-hmm.
And I say that as a graduate of Minnesota, we had occasion, University of Minnesota, we had occasion to go on to the Indian reservation and look
Okay.
at the medical care there and, the institution. It was interesting and it was a wake-up call when I worked with the Oglala Sioux, and in medical care, when someone presented, if they had excellent physicians, don't get me wrong, they had excellent physicians, but the patient would not respond until the local shaman
Mm-hmm.
basically came in. We have to learn this with our community, regardless of what the community is. How do we don't force environmental health on it. We have them accept environmental health through recognizing that community. And that becomes part of environmental health. The science, fitting the science in a social
Translating the science
science into a
into the
social
community
construct.
discussion. Right.
Yes. So
So
that's one of the biggest things that we have. And right now, I think we're too far structured. Here's a
my final thing I'm going to be bringing up
yeah,
with you because we're running out of time here is
okay.
really what I want to talk to you about what was environmental health like when you started. You talked about that, the dairy, whatnot, how it's changed. You did talk about that, and you're really talking about now the future, aren't you? We've
Yes,
got a lot of the procedures in place. We've got to deal with AI, but AI, you can't translate AI into whatever community that may be. Prisons, nursing homes,
true,
Ogallala Sioux,
true,
inner city, rural.
true.
They're all
It's true.
different.
They're
How,
all different, but we have to get back to that basic science. And
okay.
what I would like to see before too long, I would like to see NEHA embrace this. We're not doing this now, but the fundamentals. There was
Now, the
recently,
fundamentals, you meaning the fundamentals of science, how we communicate
exactly,
environmental health science
science
for all
throughout,
these
but
communities.
also our technological skills going to how how do we inspect? It's one
Mhm.
thing knowing the code, but it's another thing, the inspection process is formalized in most countries, particularly Europeans. Here, you have a computer,
Sure.
you go out, and I wouldn't say that we could be far more effective if
Okay.
we knew what we were doing and
That we're
teach
giving
some of those.
substantial information, not just procedure. We're not
Yes,
just checking off.
yes, yes.
And
Yeah,
I think
and
that would be,
that goes with inspection procedures, how to inspect basically, how to sample,
yeah.
how to use our instruments. You see what
But,
we
but,
write
but,
in the
yeah. And
journal.
what you're trying to do is enlighten the community. This is why we do things this way, because it's going to protect you. We're not just trying to figure out, sign off information. We're doing it for a reason.
We're signing off information now in
Yeah.
far too many, because I get to the affiliates and you get the feeling there are some that are really engaged in environmental health, but others, no, it becomes a routine. And there, I learned a long time ago, our profession comes in two flavors: technician and technologist. A technician is someone who will go out there with a check sheet and do just that. And
The
we
procedure
have
side.
now, yeah, we have technicians uh, here in our state. We have
And that's AI
technician.
too. Right.
That's fine, fine. But the technologist is the one who's trained. And I could think of some of them, like the guys I write with, our toolkit column. They're technologists, every one of them. Think of what uh, think of what guys like Vince Radke have accomplished in their life
Sure.
with smallpox and that kind of business. Um, all of us have a record of publication and so on. So this is a technological skill, and I would love to see NEHA embrace that. We kind of have that with the American Academy of Sanitarians.
Gotcha.
That's been there. But even there, the distinction is you could do anything you want. But if you have a master's, you're in, that type of thing. And if you've written a paper,
Yeah.
I would like to see that expanded, and particularly NEHA expanded into technician technologists, because now technicians can make a hell of a lot of money, and technologists should be recognized making a lot of money.
We got a situation. Yeah, and I understand where you're coming from. We've got an advancing situation out there, and of course, the pressure we feel is from policymakers, etc. Why do you have to have an RAHS? Why can't we just get a high school student out there? Because all you're doing is checking these things off. And I think you
we're
make
not
a good
justifying
point.
it.
Yeah, because
Yeah, we're
then
not
you make a good
justifying it.
point. If you're trained, educated, and you're providing that information, then you're worth the credential, and then you're worth your salary.
It's interesting. If I take someone through one of my facilities, whether I go to a large food manufacturer and work with listeria, or I go into my prison, or I go into one of my nursing homes, if I take someone through and say, I'm going to show you how I view my environment through the eyes of a sanitarian, my God, does it open up. It opens up their eyes. I never saw that before. I never realized that before.
You've never learned. You've got the insights that you can talk about that. It's not going to be in a book. It's not going to be on the check sheet. It's not going to be in the food code. There are things out there that you just need to know.
You need to know. And it comes with experience, but it also comes with some training. We have enough historically. I even have it here. I've been trying to work on it. We did something out of NEHA. I've been playing with this thing, Detention Facilities Handbook.
Okay.
And it was done back in, when the hell was it done? I think somewhere in 83.
Okay.
This thick. I want to redo that. So detention facilities, this goes all the way from ICE facilities, which I inspected, all the way down to lockups in a police department. This is what we need to be looking at, and then applying environmental health sciences within that environment.
Gotcha. So let's close up. We're already over time. Final thoughts. It sounds like we need to go beyond AI. We need to go beyond procedures. You got to understand what a technician is and pay for that service. And then we got to be able to communicate the basic science into every one of our communities. As you apply it to that community, it's going to change. Different rural, different for urban, different for prisons, different for schools, but they have to all apply to the same standard. How are we going to get there? and keep it quick.
I really don't know. It has to come from within. We have to recognize where we are in terms of public health. Right now, when I look at groups like APHA, they're policy centric. And when I say that,
Okay.
it's more gender related, race related, policy related, with nothing substantive behind it, because then I said, I got to fund that stuff. You know
Sure.
why?
Yeah.
If we were to translate what we do, even stuff like food protection, but embrace what we do into what IAFP does, and the
And
manufacturer
IEFP stands
IA
for
International Association of Food Protection.
okay.
They used to be IMFS. They have
Sure.
they have the sanitarians, but they're industry sanitarians.
If they're going down, go ahead.
If we need to embrace what they do and how they do it, because they're dealing also with food.
Right.
How do you do this? And how do you distinguish between food manufacturing, which HACCP works well, and then retail food, which HARP C works well? How do you balance those things out? Now we can explain what we do. It's not one size fits all. If we start looking at something like this and just take out the politics, take out the demographics, take out all the extraneous stuff, and get back to a science.
Okay. Let's get back to the
Now,
science.
yeah, get to the science. I think it'll
can
evolve
justify
beautifully.
Yeah, we
it'll
can
evolve
justify
beautifully.
ourselves. All right.
Yes.
Bob, with that, I'm going to say on behalf of NEHA, thank you for your 60 years of service. I hope you have another 60 years, but it's always a pleasure to chat with you. You've got insights that I think very few people have, that we greatly appreciate.
Well, if you guys want, it would be nice to do a round table with some of the old timers and then some of the new up and coming people, because they're two different schools of thought here, basically. I think right now, the ones who are probably the best trained are public health service sanitarians, or whatever they call themselves.
You're talking about the U.S. Public Health Service?
Yes, I think they're the best trained, and they have a good long history of they learn through crisis management. We learn, you don't learn very much through rote stuff, but you do learn through crisis management. That's how I learned, particularly with institutions. They do that regularly. Things like East Palestine and these incidents, Palestine, really are learning experiences. So these people need to be involved. Okay, what did you do? Can you translate what you did into a science? How do we describe that for our profession? I remember, just as a closing note, my father was a tool and die maker. And as a tool and die maker, I used to, kind of look at him and say, Pop, I got this. Can you make it? And an old German, he put his glasses down. No, yeah. And then go down the basement. And then within a couple hours, there.
Yeah.
And he knew what he was doing. There was no such thing as hesitation. I've become my father within my profession. I'm not afraid of anything. I could be thrown into anything. So, and I'll find it, simply because all I do is read and work. And I think this is what we try to strive for. make it easy. So I don't come in with a check sheet. I come in with a pad and a pen and my instruments, because all they are is an extension of my senses. And then I could do things. Once I have that, now I can explain what it is.
That's great to know. Bob, again, thank you for your time this afternoon. Thanks you for your 60 years of service. We will always be in touch. I love some of your ideas, and we're going to follow up with them. On behalf of NEHA and Advocacy Insights, this is Doug Farquhar. Have a great afternoon.